Good evening. Today I'll be presenting a case of toddler with bony. A 1 year, 2-month-old toddler boy, born of first order to non-consanguineously married parents, hailing from Ellery in Cuddalore district, was brought by the mother whose reliability was good, with complaints of deformity of legs in the form of bending noted by the mother for the past 4 months. Child was apparently normal according to the mother until 4 months ago. Mother then noticed a progressive bony deformity of lower limbs in the form of sideward bending of both thighs and knees away from each other as he began to stand. On further probing, mother also gives a history that the child has difficulty in walking compared to children of the same age group. For the above complaints, the child was taken to the district government hospital a week ago, where he was evaluated and told to have vitamin deficiency that required oral medications. The child is yet to start receiving the oral medications. Mother did not notice any obvious short stature when compared with children of the same age. She also had not observed any wrist deformities until she was informed by the doctor a week ago. Mother had not appreciated patchy or excessive hair loss as seen in vitamin D deficiency dependent rickets, visual problems as seen in Lowy syndrome or cystinosis, yellowish discoloration of eyes and abdomen distension as seen in hepatic involvement, or hearing difficulty or delayed dentition. There was no preceding or associated history of pain, fracture, or seizures as seen in hypercalcemia, frequent urination, increased consumption of food, preference for salty foods as seen in renal diseases, frequent loose stools, foul-smelling stools, or bulky, greasy stools as seen in malabsorption, recurrent respiratory infections as seen in cystic fibrosis, or any drug consumption such as anti-epileptics or anti-tubercular drugs in the past. There is no history suggestive of any chronic illnesses involving the lungs, the liver, or the kidneys requiring medications or follow-up in special clinics, and there is no past history of such admissions. Antenatal history.
Wait.
Yes, sir.
Okay. You almost completed all the points, Janapriya.
Yes, sir.
Yes?
Yes, sir.
Okay. Certain things you have told us. The usual complaint, of course, the deformity may be there. But what will be the usual complaint? The child comes for rickets. If the child has rickets, what is the usual problem they come for?
Delay in walking, sir.
Delayed walking. Yes, good. Maybe delay in walking. Then?
Delay in walking will be the most common complaint, sir.
Common
Otherwise, it can
complaint.
also present, yes, sir. Symptomatic hypercalcemia can also present.
That is very rare. Symptomatic hypocalcemia happening and producing tetany can happen, but it's very rare. Frequent tripping while walking. While walking, the child usually falls suddenly. This may be the usual complaint they come. You know the reason why they have the frequent fall while walking?
Hypotonia, sir.
Not exactly hypotonia. Hypotonia is not a very marked feature in rickets. It can happen.
Due to the skeletal deformity, sir?
Deformity may be one of the reasons. The stability of the joints. Because of the laxity of the ligament, the child may not have the stability of the joint. So while walking, the stability will not be there. The child frequently falls. This is the common reason why the child comes usually. Okay, this is a little older child, 1 year and 2 months old. 14 months old child. Okay. For younger child, any particular complaints? Say in infants, say 4 months, 5 months. If they have vitamin D deficiency, any particular complaint you always consider the vitamin D deficiency?
Sir, hypercalcemic seizures might be there in younger infants.
Okay. If any seizure in this age group, we want to rule out the possibility of hypocalcemic seizure due to vitamin D. Accepted. It is accepted.
More than the symptoms, some smart mothers will identify some signs within the baby.
Signs.
And then they'll bring to the doctors like saying that this is a problem. So what could be as Sarah asked, what could be in the infancy age group? You're saying delay in walking. This because this is a 14 months old child where the child needs to walk. But suppose as Sarah is asking beyond 3 months to 1 year where the child normally is not supposed to walk. So what are the other symptoms or signs that the mother can notice and bring the child where you'll suspect as rickets?
When the child is crawling, they can observe some wrist deformities, sir, because that can occur early during the
Yes.
crawling age. Yes, sir.
Now,
Okay.
what
And
kind of wrist deformity? What is that? Then mother will come and say, just
wide wrist, sir, widening of
yeah,
wrist.
Widening.
okay.
And craniotibis can also be appreciated by the parents also, sir.
Very unlikely, ma. Very unlikely.
Yes, sir.
Commonest sign, symptom, what I wanted to know is this excessive sweating of the scalp.
Forehead sweating, that is
Scalp
one
sweating
thing.
is very common. Okay. This is unexplained. Why it happens in vitamin D, we do not know. But if the mother complains of excessive forehead sweating or scalp sweating, consider the possibility of vitamin D deficiency always.
Okay,
Okay.
sir.
This is
Okay,
one
sir.
of the things we clinically in practice, we come across this problem. That's why I insist upon this. Of course, this restlessness, irritability, all may be there.
Irritability, yes.
Irritability, all excessive cry, all may be there. And one more thing you told, vitamin D deficiency and maybe cystic fibrosis producing recurrent respiratory tract infection.
Yes, sir.
Is it that's the only reason or any other reason
No,
also you
sir.
have?
Because of hypercalcemia, there will be softening of the costochondral junctions, sir. So it might cause even atelectasis, and they may be more prone for pneumonia, sir. Because
Vitamin
of the rib
D
softening.
per
Yes, sir.
se is known to give protection against respiratory tract infection. Okay.
Okay,
So
sir.
in the deficiency of vitamin D, the chances of getting recurrent respiratory tract infection, V's-associated LRI are all known to happen. There are a lot of studies that are going on. By giving vitamin D, you can reduce the number of episodes of respiratory tract infection in infancy. Okay. This may be one of the other reasons also. Because of the hypotonia, then again, the chances of getting respiratory infection may be there. Okay. And you told about the anticonvulsant drug. Anticonvulsant drug, what drug responsible for rickets mainly?
Phenobarbital and phenytoin, sir, because they interfere with the hepatic cytochrome P450 and they cause increased degradation of vitamin D.
Yeah, good. That's the reason is being given. Okay. That's
Any
one of the
other
important
drug
reasons.
you can expect to
Sir,
cause?
anti-tubercular medications, sir, isoniazid
Yes,
and
rifampicin, yes. Of course, what you said is also one way correct regarding the atelectasis, the decreased softening and decreased movement of the chest. That is also one of the factors which make the child prone for respiratory infection. As sir said, in addition to its anti-inflammatory or anti-infective action, this also is found to be one of the causes for atelectasis and pneumonia.
No, Janapriya, you are telling this history is the child has got a delay in walking.
Yes,
I would rather say this is more of a muscle weakness rather than a bony involvement. How will you rule out it is a muscle weakness actually? I feel it could be a motor weakness of the lower limbs alone, rather than a bony involvement.
So the hypotonia might have been present since the earlier age too, sir, and there is also
No, is the
associated
child,
skeletal
it's a 1 year, 2 months old child actually. Is the
Yes,
child,
sir.
what is the child able to do now actually? You said like the child is not able to walk,
Yes,
but
sir.
is the child able to stand on its own with support and
Yeah,
stand on
yes.
then or hold an object, or is not even able to stand from the sitting position?
All the other domains are not involved. So the child is able to stand with support, sir, but is not able to like take few more steps, sir. I have mentioned that in the
Okay,
history.
so you want to say there is no muscle weakness, right?
Yeah, yes, sir. Yes, sir.
So generally in rickets, what kind of muscle is it? The more proximal muscle involvement or is it distal muscle involvement?
Proximal, sir.
Right. Okay. So that generally in rickets we get more proximal muscle weakness rather than distal muscle weakness.
Yes, sir.
Okay.
Proceed.
Antenatal history. The age of mother conception was 26 years. The pregnancy was spontaneous after 8 months of marriage. The mother was registered and immunized. He is the firstborn child with no previous abortion, and the mother did not consume any iron, folic acid, or calcium supplements throughout the pregnancy. The first trimester was relatively uneventful. The second trimester, the antenatal scan was told to be normal. The quickening was felt at 16 to 20 weeks with no bleeding or draining PV. In the third trimester, the mother said the fetal movements were pursued well throughout, with no history of fever with rash, drug intake, or radiation exposure. In the natal history, he was delivered at term by LSCS following a failed induction. His birth weight was 2.5 kg. He immediately cried at birth and was initiated on breastfeeding after 1 hour. He passed urine and meconium on day 1. There is no history of NICU stay, seizures, jaundice, or umbilical cord infection. Can I proceed with the developmental history?
Now, what is the
before
significant?
Postnatal, antenatal, natal, postnatal was uneventful.
Yes, sir.
Postnatal, how early the breastfeeding was started?
Initiated after 1 hour, sir.
1 hour.
1 hour.
Okay. Okay. Any other thing? And
now, what is the significance of antenatal history with respect to this patient? Why do you want to ask such a detailed history? See, why you said that mother has been properly registered, immunized, but why was not it given iron, folic acid, calcium supplements? They have had a proper checkup. They have done an antenatal ultrasound, but still mother has not taken iron, folic acid supplements, or she was given, or she had a poor compliance. Or what is the significance of antenatal history with respect to this patient? Why do you want to ask such a detailed antenatal history for this child, where you feel it is more of a acquired condition, no?
Yes, sir. Maternal vitamin deficiency can also congenital rickets. So I was going in that direction. Because maternal.
Okay, congenital rickets, but the age of presentation of this child is such as only at 1 year, 2 months.
1 year, 2 months. Yes, sir.
Now, why do you want to suspect as probably? I mean, not a, how do you want to rule out a congenital rickets? Then in this case, it's not just like a congenital rickets.
Okay, sir. Sir, rickets can also present in the background of renal diseases. So antenatal scan could pick up some CACUT or any IUGR2. So that's the reason I had probed for the second trimester history, sir.
No, probably you're right. Actually, see, you said why we are looking for antenatal ultrasound and other things, probably to rule out other conditions like any skeletal dysplasias, where there has been polyhydramnias or hydramnias, or the frequent measuring of the length of the babies at frequent ultrasound abdomens, probably to rule out other conditions of skeletal deformities. Probably finally, then we can say this other conditions have been ruled out. This is an acquired condition. So that is the significance of getting an antenatal history. Why the mother has, and similarly, if the mother has taken any anti-epileptic medications or radiation exposure in the first trimester. So that is the significance of antenatal or natal or postnatal history. But as Sarah asked, like postnatal history is very important in this child actually. You have not mentioned anything about the postnatal history because when was the child breastfed and how long was the child exclusively breastfed and when did they start the weaning food? So all those things, I mean,
postnatal history, you have not mentioned anything about any jaundice, anything was noticed. Where was the child? You said child was delivered in KGH, Kosha Hospital.
Yes, sir.
Okay, how long the child was in the hospital? Is there a postnatal period was uneventful? If there was any problem? What problem you expect in a case of rickets, if at all?
Hypercalcemic seizure, sir, in the immediate neonatal period.
Ma, how common is hypercalcemic seizures, ma?
Sir.
Vitamin D deficiency producing hypocalcemic seizures. How common it is?
No, not that common, sir.
Not that common. It happens. We have to rule out. We keep this in mind. I'm not saying that it doesn't happen. We have to watch. We have to look for it. Okay. Okay.
When does it usually occur, Dr. Janapriya? If it is hypocalcemic seizures after birth?
When the child is started, if the mother is not on any vitamin D or calcium supplements, it can even occur in the immediate neonatal period, sir, or during the weaning period also it can occur, sir.
Yes, they have found it even in the first few days also. Sometimes it occurs, they are found out.
Yes, sir.
And you said it is a term cephalic presentation.
Yes,
what do you expect in case you are suspected the mother to be having rickets or some problem?
If the mother also has short stature and triradiate pelvis, mother also has rickets, that can also be a cause for failed induction, sir.
Okay.
Why LSCS, ma? Failed
Because
induction.
of failed induction, sir.
Failed induction.
Yes, sir.
Okay, birth weight was 2.5. Any significance? Any importance? Birth weight was 2.5 in this child.
So we can rule out IUG as but birth weight 2.5 is on the borderline, so less than 2.5 is considered as low.
So whenever the child has to catch up growth,
yes, sir.
the growth rate is going to be more. Okay, then
Okay,
the chances of going for rickets is more. The chances of rickets, it is the disease of the growing bone, no? So
yes,
the chances of rickets is more if the child is preterm or if it is low birth weight. Okay, it's one of the reasons. Okay. Okay.
Yes, sir.
Why
and
it is
usually postnatal period, you need to know about any jaundice, any stasis, what is it, congenital
Genital cholestasis.
biliary atresia, anything is there, all that we have to keep in mind. So usually we used to go into the details about postnatal also. Natal history, postnatal history, antenatal history, everything is important to find out whether it is going to be any congenital rickets or any other problem. Okay.
Okay, sir.
in preterm? You said no. It is if it is a preterm, it can have. So why preterms are more prone or very low birth weight?
Usually the calcium and phosphorus deposition from the mother to the fetus happens in the third trimester. So preterm children are more prone for osteopenia of prematurity.
Yes.
Which can yes, sir, which can present as rickets in the growing periods in the infancy.
Okay.
Was the child put on any vitamin D supplements regularly post delivery? I mean, post from the immediate newborn period, was it given?
Sir.
Not
Child
given.
has, yes, sir.
Please ask that question also, no? Because routinely nowadays we supplement irrespective of the term or preterm gestation. So routinely we give it till 1 year of age completion. So whether the child was prescribed or not taken, poor compliance. So probably that history also you can just maybe you can just mention a word about it actually.
Okay, sir.
So what is the dose you give for this term child? What is the dose you give probably routinely for?
400 international units per day, sir.
Okay, till?
Till infancy, sir.
Sorry?
Till infancy.
Till infancy, sir.
Okay, till infancy. Suppose if it's a preterm?
So preterms require we can up 400 to 800 international units per day, sir, with calcium supplementation of 50 to 75 milligram per kg per day, sir.
But nowadays, even for preterm, we just stick on to just 400 international units per day. No, we don't give 800 international units per day. But is there any difference of vitamin D supplements for the children of mothers who are for the children who have been exclusively breastfed or who have been formula fed? Is there any difference in the dosage of vitamin D?
So, breastfed per se has only international units of vitamin D of 12 to 60, so they will receive 400, sir. There is formula.
Okay.
It also has like a good composition of calcium vitamin D, but there is no difference in supplementation. We stick to 400 IU per day.
Now, which milk, breast milk or formula? Which I mean, either breast milk or formula fed, which one has got more of vitamin D content?
Formula milk has more vitamin D content, sir.
So irrespective of the milk, whether it's breast milk or formula feed, all babies till infancy are routinely given 400 internationals per day of vitamin D supplements.
Yes, sir.
Okay, please proceed.
What is the vitamin D content of breast milk, ma?
So 12 to 60 international, sir, approximately.
Per 100 ml per liter?
Per liter, sir.
Per liter.
It
maybe
is per liter,
up to
actually.
100.
So averagely,
100 IU per liter. 2200 IU per liter, actually. Okay, it varies. It depends upon the maternal supplementation of vitamin D. And that's why even postnatally, I mean, even the third trimester, the mothers are being now planned to give vitamin D dose and to watch for the children between the maternal vitamin D and the baby's vitamin D content. Studies are going on. Okay. Okay, ma. Proceed.
The developmental history of the child. He attained head control at 5 months and was able to sit with support at 6 months of age and without support at 9 months of age. He started crawling at 10 months of age and was able to stand with support at 11 months of age. Currently, mother said he is not able to take more than 1 or 2 steps with support. He started grasping objects with both hands at 5 months and was able to transfer objects at 7 months. Currently, he's able to pick up objects. He started cooing at 3 months of age and turned his head to sound at 5 months of age. He started babbling monosyllables at 6 months and bisyllables at 9 months. Currently, he's able to speak 2 to 3 words. He attained social smile at 3 months and recognized the mother at the same age. Parents noticed stranger anxiety at 7 months of age and he started waving bye-bye at 9 months of age. Currently, he plays simple ball games. Moving on to the
your developmental history, what does it help you in ruling out?
Sir, it shows that only the motor domain is affected, sir. All the fine motor, language, and social domains are fine. So it shows that the child does not have any mental retardation or anything like that.
Yes, it is ruled out all mental retardation and other
and
things.
all the other. Yes, sir.
Okay.
Social smile, you have said 3 months more. It is little on the higher side. Okay. Social smile usually 6 weeks to 2 months.
8 weeks. Yes.
Okay. 8 weeks.
But
Okay.
how often do you have a higher mental function defect in the rickets, Dr. Janapriya? You said, like you wanted to rule out higher mental function disability, but how often do you see higher mental function disability in rickets actually?
So,
why do you want to ask for such a detailed?
But rickets secondary to renal diseases like Lovis syndrome, which is ocular cerebral renal syndrome, can present with mental condition, and also in the mucopolysaccharidosis, such as Marcus, which present with bony deformities. So they can have this. So that's the reason, sir. Based on the bony deformity, I just proceeded with those.
Right. Okay. Yeah.
Nutritional history of the toddler. He was excessively breastfed till 6 months of age, and he's still continuing on breastfeeds till now. He takes breastfeeds about 2 to 3 times per day. He was started weaning from 7 months of age. He was never on any oral vitamin D supplements. He does not consume fortified milk. The cow's milk that he consumes is used only in preparation for his kanji. The cow's milk is obtained from the vendor and is diluted with equal parts of water. He does not consume any eggs or fish in his diet. So, in this, the 24-hour dietary recall, in addition to breast milk, we found that he consumes only 600 calories per day and 15 grams of protein per day, and he's at a calorie deficit of 400 kilocalories per day.
Okay. About the breast milk, she had been exclusively breastfed for 6 months and not supplemented with vitamin D. Is it important, no? Yes, exclusively breastfed for 6 months, but not supplemented with any vitamin D or any fortified milk formula or anything. Okay? Okay. Then, weaning was started by 7th month. The weaning
after
food
6
you have
completed
not.
Months,
Okay. She has not given any first-class protein. What food which contains vitamin D she had given for this child?
No,
any food?
Egg yolk can be started, sir, but mother has
but
not.
You said no eggs, no fish consumption.
Yes, sir. She has not given anything, sir.
How much the egg contains vitamin D?
Sir, it has
roughly 40 to 100 IU. One yolk contains only 40 to 100 IU. The child requires at least 400 IU per day. Okay? Okay. Any, is she no fish consumption at all? Is she a vegetarian or a non-vegetarian?
No, sir. They are, the family has a non-vegetarian diet occasionally, but.
Any vegetarian food, vitamin D? My patient is a vegetarian patient. She wants to know what vegetarian food she can give.
Some mushrooms can provide vitamin D, sir.
Good. Mushroom and yeast are the only sources. Yeast and mushroom are the only sources. Otherwise, any fortified formula milk, fortified milk, those are the only sources. Otherwise, there is no vitamin D source for the vegetarian food. Okay?
Okay,
Vegetarian food is very poor in vitamin D. It needs to be supplemented.
yes, sir.
Okay. Okay.
What about the cow's milk you had mentioned? How much vitamin D you expect from that?
Cow's milk, 100 ml of cow's milk will have 50 to 60 IU, sir.
Per?
Per 100 ml, sir.
No.
Only
It
two,
is again per.
very less, 2 international
It is again per liter.
Liter, okay,
per
sir.
liter only. Yes.
Okay, sir.
Liter.
And that too
Not for-
diluted, it will be still less.
Yes, sir.
Little more than the breast milk, but it is not sufficient. Again, there also it is per liter. It is not sufficient.
Yes, sir.
Okay. Okay. Which food contains high vitamin D? Foodstuffs which is having high vitamin D content.
Sir, chicken liver, sir.
No. Chicken liver all contains, but not very high. The high content is seen only with marine
Fatty
food, fish. Fish
Salmon
liver.
fish,
Fatty
no?
fishes, fatty
Salmon
fishes,
fish.
sir. Salmon.
Salmon fish. That's the one that contains the highest vitamin D content.
Okay, sir.
Yes. And the total calorie deficit here is
400 kilocalories, sir.
400. That is 40% is the deficit. The child
Yes,
is
sir.
receiving only 60% of the total calorie.
Total calories.
Okay.
Yes, sir.
Protein almost
Yes,
is all right. Preschool, okay, it is 1 year, 2 months old child getting around 15 grams of protein. Okay, fairly it is all right, but not getting any first class protein except some diluted milk.
Milk, yes, sir.
Otherwise, there is no first class protein. What is first class protein?
Sir, which contains a higher amount of
Higher amount.
nitrogen NPU ratio.
No. I am not asking about net protein utilization. I am asking about what is the first class protein.
From animal sources.
Animal source. Okay. Complete protein.
Both are the same for first class or complete.
Which contains all essential amino acids. Which contain all essential amino acid is considered as
Complete protein.
complete protein. Vegetarian proteins are incomplete. Is it right? Vegetarian protein are incomplete. They need to be supplemented. You give rice with sambar. Okay? Okay, we are diverting. Okay, proceed.
Immunization history, he had received only the birth vaccines, BCG, OPV, and Hep B. No other vaccines were administered. Family history.
It is really shocking to see know this ma. Coming from Kadalur district has taken only the birth vaccine, and it is the birth order also is the first child, not received any of the vaccine. What is the cause? What is the reason for not receiving the vaccine? Any specific reason? You have probed the mother?
The mother said they just don't go out much, and because the child didn't have any illnesses, she didn't feel the need to go to the clinic, sir. That's what she said.
But nobody has informed her about the vaccination. She was delivered here in KGH hospital
she
in
had
the government
card,
sector.
She said she was supposed to follow up, but because she felt the child didn't have any illnesses, she didn't feel the need to get vaccinated.
Is she aware about the vaccination has to be done? 1.5, 2.5, 3.5 month vaccines?
Yes, the mother had the card with her, sir, but this was the reason said by the mother, sir.
Is it the reason being, is she an working mother going for the job, not having time, or is she an illiterate mother, not knowing about what is to be done? Because this immunization in Tamil Nadu, if people are not receiving the government side, it is really shocking for us. If it is from the neighboring state, we will accept. We will usually say, yes, it is from neighboring state, not from Tamil Nadu. You know the coverage?
I don't think so. Mother is illiterate, sir, because she has, in her pregnancy period, she has got properly immunized and she has had a regular checkup only.
Regular checkup and not given any of the
not given any medicines. She has not taken.
Not taken vitamin D supplementation, not given any of the doses of the vaccine. It is really surprising to see in Tamil Nadu actually. You know about the coverage here, vaccine coverage by the government sector. our figure is around 75 to 95%, depending upon the areas for the primary immunization.
No,
Okay,
even
proceed,
if they
Ma.
don't go, no, the village health nurses go and visit
Incomplete.
their houses,
Yeah, they go and
especially
visit
after
and give.
delivery. Hmm.
Incomplete immunization, they must have received 1 or 2 doses.
Okay.
I don't know why she has not received not even a single dose after the birth vaccines. Okay, proceed, Ma. Proceed.
Yes, sir. A family history, he is the firstborn child out of a non-consanguineous marriage. There is no family history of similar complaints, short stature, chronic liver diseases or renal diseases, and there is no history of bony deformities in the mother.
Did you notice the height of the mother, Ma?
Yeah, yes, sir. Mother's height was 140 centimeters, sir.
140, 140.
Yes, sir.
It is in the borderline.
Yes, sir.
Borderline.
Borderline, sir. Less than 140 short stages.
So you also mentioned the height of the mother also has to be routinely mentioned.
Yes, sir.
Okay.
Okay.
What is its significant family history?
Sir,
For
sometimes
rickets.
even X-linked hypophosphatemia rickets might go unnoticed in the mother, sir. And if there is a history of sibling death, we can suspect cystinosis, sir, in early infancy.
If it is hypophosphatemic rickets, what is the mode of inheritance?
Recessive, sir. X-linked recessive, sir. X-linked
X-linked?
X-linked hypophosphatemia, sir.
X-linked. Is it recessive or dominant?
Dominant or
Dominant, sir. Dominant,
dominant?
sir.
It is the only classical example for X-linked dominant inheritance is your hypophosphatemic rickets. Okay.
Yes, sir.
Okay. Then many of the diseases like your cystinosis, other things are all autosomal recessive.
Yes, sir.
Autosomal recessive. So it may be significant. Okay, family history. No other family member is suffering from similar such problem.
No, sir.
Okay. Yes.
Socioeconomic history. The child lives with his father, mother, and grandparents in a Pakka home, which has one kitchen, bedroom, and toilet, which is a rented house on the ground floor of a 2-story building. The sunlight exposure is limited as the child does not go out to play much, and there are two tinted windows in the living room. Their religious affiliation is Islam. The father, who has completed his primary school education, works as a daily wage laborer with a monthly income of 3,000 rupees. The per capita income is 600 rupees. The mother is a housewife. According to the modified Kuppasamy scale, they belong to the upper lower class with a score of 5.
So exposure to sunlight is almost nil. The child has been not taken out of the house. It is inside the house all the time. Is it right?
Yes, sir. Yes, sir. Yes, sir.
And the window also only 2 windows which are tinted.
Yes, sir.
Tinted glass or
They
glass
said
windows?
rose-colored glass in the living room, sir. Tinted glasses.
Okay. What is its importance?
Sir, tinted windows block out the UVB rays, sir, and if the child does not go out to play, the child also does not get any sunlight exposure, which is more important for synthesis of vitamin D, sir, rather than the nutritious sources.
She is in Kadalur district.
Yes,
What is
sir.
their job? Is it farmer or is he a farmer?
No, sir, he is a daily wage laborer, sir. He supplies the water cans he distributes water cans. He works for a person. Yes, sir.
Okay. Which part of the day sunlight has good ultraviolet rays for vitamin D synthesis?
Sir, around 11 a.m. to 3 p.m., sir.
11 a.m. That is mid-morning. Mid-morning, 11 a.m. to 3 p.m.
3 p.m.
How long the exposure has to be there
Sir,
to get the vitamin D?
For a fast-skinned toddler, at least an area of 20 centimeter square should be exposed for a minimum of 30 minutes, sir.
30 minutes in a day or what?
11
in a
a.m.
day,
to 3 p.m.
Yes, sir.
30 minutes in a
Day, sir.
no. It should be 30 minutes in a week, actually. No.
Okay, sir.
No,
See, again,
no, sir,
depends.
no, sir. Per day,
Per
sir.
day,
Per
sir.
day.
Per
That
day.
will
Okay.
help
Okay.
synthesize 10 microgram of vitamin D.
No, that's what. No, first thing what you said, like 30 minutes in a day. Before that, what you said? Area?
Sir, any
50 square.
fast-skinned toddler with 20 centimeter square, sir, at least like a cheek area, unexposed area. Either it can be cheeks or limbs without covering and sunscreen, sir?
Actually, roughly 18% of the body surface, if it is exposed,
Okay, sir.
even for 10 to 15 minutes, the vitamin D level increases by 4 nanograms. That's what they have done some studies. And what is solar zenith angle?
Not sure.
The UV rays, if they come directly above the head, then the ozone actually prevents it from, if it comes at an
Absorption.
angle. So only the direct rays will reach the surface. So the angle which is formed by the sun, suppose it's at a higher latitude, then you get slanting rays. So that angle will be wide. So the amount of vitamin UVB rays reaching the child will be less.
Yes, I understand the significance, sir. It will be when the sun is away from the equator as in the winter.
Yeah, correct. And so they say for a child, 10 to 15% of the surface, if it is exposed, they are able to get the sufficient to increase by at least 4 nanograms.
Okay, sir.
So every day the child has to get exposed at least half an hour per day
Half an hour.
to the sunlight. This is also mid-morning sunlight. If they get exposed to all these days, what is the problem they can face?
Sir,
You are aware?
which one,
If
sir?
the child gets exposed for at least half an hour every day, what is the problem they may face? Every day, if vitamin D has to be produced naturally, the child has to get exposed at least half an hour every day, ma. Okay.
Yes, sir.
Yes. If they get exposed to this extent every day, the chances of going for basal cell carcinoma of the skin is very high.
Hi, okay, sir.
Okay. This is the other problem.
Yes, sir.
In the last century, we used to say, usually if the sunlight, early morning sunlight is very good source for ultraviolet rays. Okay. The reason what we used to say is the atmospheric pollution is less. But then by various studies, now this century we have shown this mid-morning exposure, which is this angle by which the ultraviolet rays falls on the skin. And the vitamin D synthesis is very good. This is what is being done now. Okay.
Okay,
and one more important factor here is this exposure. This exposure, this is only a meager amount actually. You need to supplement by some means. By natural way of getting vitamin D is always less only. Who are the good people to synthesize vitamin D? People at tropic or otherwise fair skin individual, dark skin individuals?
Fair skin individuals are more conceived. There is hyperpigmentation. The melanocytes themselves interfere with the UVB. Yes, sir.
So dark skin individuals have less ability to synthesize vitamin D when compared with fair skin. Okay?
Yes, sir.
Okay. And the Asiatics, Southeast Asia's Asiatics are very poor in their vitamin D level. Okay. This is one of the important things observed in the abroad. Okay.
Yes, sir.
Type of skin also they say. Okay, that is what fair skin type 1, then darker comes under type 6. So 5 and 6 is a dark.
Okay, sir. Can I proceed, sir?
Yes.
Yes.
Summarizing the history, a 1-year, 2-month-old male toddler born of first order to non-consanguineous marriage, brought by the mother with history of bowing of legs for the past 4 months and difficulty in walking, without alopecia, dental abnormalities or recurrent fractures, no systemic illnesses or chronic intake of drugs, with dietetic assessment revealing calorie deficit, not a balanced diet, no additional milk and no vitamin D supplementation, partially immunized, with no family history of similar ailments and lack of adequate exposure to sunlight, I would like to think in terms of rickets. With this background history, I would like to proceed with general examination and systemic examination.
Okay.
You had written about alopecia, dental abnormalities, recurrent fractures. But in the history, you never mentioned about that.
Sir, I did. I have mentioned that the mother had not.
Okay.
Mother had not
Noticed
appreciated
any
patchy or excessive hair loss, delayed dentition, sir.
Okay.
Yes, sir.
No, even in certain types of rickets, VDDR, you get alopecia, no?
Yeah, yes,
Without
sir.
alopecia,
No, because the okay, so I should have etiology should be nutrition. Should I mention in summary itself, sir?
okay. And now recurrent fractures. What do you want to know? How often do you see recurrent fractures in a child with vitamin D deficiency?
Not.
What will you suspect if you have a child with recurrent fractures?
Sir, osteogenesis imperfecta, sir. That can also present.
Yeah. But we don't see very often recurrent fractures in a vitamin D. No, we
Yes,
do
sir,
see,
yes.
but only thing, the first time episode we take X-ray, then probably we can diagnose. But unless it is very bigger child recurrent fractures, first thing always you want to rule out is OA, osteogenesis imperfecta.
Yes,
And again, dental abnormalities. What kind of dental abnormalities?
sir, enamel hypoplasia can be seen, sir, and dental abscesses can also present in certain conditions, sir, like
Okay.
hypophosphatasia.
Okay.
Yes, sir.
You said recurrent fractures. Any other condition where you will suspect when child is brought repeatedly with fractures?
Sir, non-accidental injuries, sir, other than osteogenesis imperfecta.
Yeah, child abuse.
Battered baby.
Yes, sir. Non-accidental
Battered
injury.
baby.
Okay, sir.
Yeah.
And probably also you said like I would like to think in terms of rickets. Do agree, but also you can also add probably a dietetic assessment revealing calorie deficit, not a balanced diet. Maybe rickets with probably protein deficiency, protein energy malnutrition. Also, I think we can add it. Just put, we know there is a clear-cut deficit of 40% of dietetic deficiency.
Yes, sir.
So rickets associated with probably some protein energy malnutrition. Maybe depending on the severity, probably I would like to tell in detail based on the clinical examination.
Okay, sir. Can I proceed, sir, with exhibition?
Yes. Proceed.
And the toddler was conscious, lying on the mother's lap, was interested in surroundings, and was interacting with the mother. He appeared undernourished. There was no pallor, icterus, cyanosis, lymphadenopathy, or clubbing noted. The vitals, his pulse rate was 120 per minute, which was regular in rhythm, normal in volume with no specific character. Respiratory rate was 40 per minute. It was thoraco-abdominal type of respiration. His blood pressure measured in right upper limb in sitting position was 90 by 60 millimeter of mercury, and he was afebrile. Anthropometry, can I proceed, sir?
Yeah, proceed.
His head circumference was 44 centimeters and his chest circumference was 44 centimeters. His HCCC ratio was 1:1. His mid upper arm circumference was 13 centimeters. His length was 69 centimeters, which fell below the first percentile, indicating severe stunting. And his weight was 7.2 kgs, which also fell below the first percentile, indicating that he was severely underweight. His upper segment measured was 35 centimeters and his lower segment was 34 centimeters. His US-LS ratio was 1:0.9, which was disproportionate for age. His weight for length was on the third percentile, which indicated that the child has moderate acute malnutrition. There was also no bony deformity noted in the mother, and her height was 140 centimeters.
Good. Okay. Now, what is your inference? Chest circumference is 44 centimeter. Mid-arm chest circumference, head circumference is 44 centimeter. What's your inference? Head circumference and chest circumference are 44 centimeters. What you infer from this?
So usually by the end of 1 year, head circumference and chest circumference ratio will be 1:1. So the growth of brain is like till 1 year of age has grown properly.
What do you expect?
Usually head
After
circumference
1 year.
will be more in vitamin D deficiency. After 1 year, chest circumference will be more.
Normally, chest circumference must overtake the head circumference by 1 year. By 9 months to 1 year, both must be equal. Okay, here it is 14 months old child. The chest circumference has not overtaken. Okay? Okay. So this is one point you need to see here. Chest circumference. This is the differential growth. The rate of growth of different tissues, the somatic growth, grows at a different velocity. The neuronal growth grows at a different velocity. But what you expect by after 1 year is the chest circumference must overtake the head circumference, which has not yet overtaken here. The mid-arm circumference is 13 centimeter. Okay. How do you measure my mid-arm circumference?
Sir, it's measured the midpoint between the acromion process and olecranon process with the arm hanging by the side of the body.
Okay. Okay. What is its significance? Any importance, mid-arm circumference?
So yes, sir. Mid-upper circumference will be decreased in malnutrition conditions.
Severe acute malnutrition.
Severe acute malnutrition.
Sam. Okay. The height of the child is less than third centile. Severe shunting.
Yes, sir.
What is rickety dwarfism? Rickety dwarfism. In rickets,
Short
dwarfism
stature
is
because of yes.
In rickets you
Short
expect
stature
short
because of-
stature because of
The bony deformity.
The bony deformity.
mainly because of the deformity. That is why it is called rickety dwarfism. You have bow leg, knock knee. Okay, because of the extremities deformities, you have the dwarfism. And this upper segment, lower segment measurement, the ratio what you expect by 1 year is around
1.7.
upper segment to 1.3, roughly 1.3 to 1.3 to 1.4 you can expect. Here it is almost 1:1. 1:1. This is because of the
Disproportionate growth.
Lower
disproportionate growth or
segment, how did you
deformity.
measure?
Lower segment.
Disproportionate growth is different.
How
Lower
did you
segment
measure?
is lower segment is measured from cubic symphysis till the heel. And out of length, lower segment will subtract to get the upper segment.
Okay, this child had some deformity, no? So
Sir,
that-
usually we'll measure the segmental length to measure the length, sir. Like from the anterosuperior spine to the knee joint length, from there to the middle malleolus.
What condition you get proportionate dwarfism? Huh? This is disproportionate dwarfism, rickets. What condition you will have proportionate dwarfism?
Sir, endocrine disorders.
Yes, yes, mainly pituitary disorders. Pituitary disorders. Okay. Okay, weight also is on the lower side, 7.2 kg only weight.
Yes.
Weight, expected weight is?
By 1 year, usually triple the birth weight, sir.
So around triple the birth weight, around 11 kg. So roughly the 40% is the less weight. Okay, 11 kg is expected. Here it is around 7.2 kg. So it correlates with her diet history. In the diet history, she mentioned there is 40%
No,
deficit.
sir. No, sir. This child's birth weight was 2.5.
2.5. When do they catch up their growth? What is catch up growth? Janapriya?
Sir, yes, sir. Sir, the accelerated growth seen in the first during infancy and till 2 years of age, sir, because of the initial nutrition deprivations, sir.
Usually catch up growth, usually the child must be in par
Growth,
with
sir.
whatever it is. By at the end of 2 years, the child must be in par with the counterpart. Okay? By 2
Okay.
years, they must catch up their growth.
Okay, sir.
Okay, whether it is preterm or any other problem, they will catch up the growth. Okay.
Yes, sir.
Weight also is 7.2 kg. Okay. Okay. So the inference from your anthropometry is, what is the inference you got from the anthropometry?
That he has
Weight is
moderate
reduced,
acute malnutrition
height also is
and,
reduced. Weight
height
is
is
reduced, height also
yes,
is
sir.
reduced. So it must be acute on chronic malnutrition.
Chronic.
Acute, yes, sir.
Acute
sir.
on chronic malnutrition. Okay.
Okay, sir.
Okay. Proceed, proceed.
Yes, sir. Head-to-toe examination. He was a fair-skinned toddler. In the head, we were able to appreciate frontoparietal bossing. The AF admitted the tip of little finger. There was no craniosynostosis or dysmorphic feces. The scalp hair was black in color, normal texture, and there was no alopecia noted.
One second. How do you look for this frontal bossing and parietal bossing?
Sir, they are seen as
Frontal and
prominent.
parietal bossing are present. How
They
do
are
you
seen as
examine
prominence.
the bossing?
They are seen as prominences in the frontal and parietal region.
Why do they get? In rickets, why do they get?
Because of the uncalcified osteoid differentiation.
Uncalcified or softened scalp bone. Okay. The parietal eminences and frontal eminences of the brain are the most protruding parts, which gives pressure over this softened bone, which gives the appearance, okay, which gives this frontal and parietal bossing. How do you appreciate this frontal and parietal bossing? By just looking straight, you can appreciate this. By looking straight, the patient you cannot appreciate. You have to look from the top. The scalp, you have to look from the top. Then only you can appreciate this frontal and parietal bossing. Okay? Tangentially from above, you must look for this. Okay. If at the little finger, tip of the little finger, PF is not closed. Okay. No craniosynostosis or dysmorphic faces accepted. Scalp wear is normal texture, no alopecia. Okay. Proceed. How to examine also is important. How do you appreciate this frontal bossing and parietal bossing? Usually we will ask you. You have to look tangentially from the top. Proceed.
The eyes show no signs of vitamin A deficiency or cataract. Ears and nose are normal. The oral cavity shows two upper and lower central incisors and lower lateral incisors. The teeth present were white in color with no dental caries or dental abscess. The tongue was normal and there was no angular stomatitis.
So no B complex deficiency, no vitamin A deficiency, no associated vitamin deficiencies,
Yes,
though the child is getting an unbalanced diet. You looked for it properly. Did you look for all this vitamin A deficiency and B complex deficiency? In the exams, be very careful. Sometimes it may be seen. Okay, always look for it properly. Okay.
You put it as moderate acute malnutrition, especially it is acute on chronic, no?
Yes, sir.
So definitely there should be some, the more common vitamin deficiency we come across is vitamin B complex. So definitely, so before you commit yourself, just you be very clear in presenting actually.
Okay, sir. The chest
You looked
showed
for,
rachitic growth.
you said you have looked for cataract. What else did you look for? Why did you look for cataract?
The cataract can be there in galactosemia and Bowley
Okay,
syndrome.
like that, any other features you look for?
So vitamin A deficiency will.
Yeah.
What is the earliest sign of vitamin A deficiency in the eyes?
Congenital xerosis.
No. Congenital xerosis is your WHO coding. X1A. Biter spot is X1B. That is all later. X1A,
Later.
X1B. That are all later. No. The earliest sign is guttural pigmentation. Guttural pigmentation. Okay. Where is the gutter?
Core.
Where the palpebral and bulbar conjunctiva meet. That is the gutter. In the lower gutter, you get the pigmentation. Guttural pigmentation is the earliest sign of vitamin A deficiency. Always look for it. Vitamin A deficiency is very highly prevalent in our setup. Okay. After the midday meal program and egg are all they providing, vitamin A deficiency is not that the amount we have seen. One of the leading cause of blindness in our setup used to be vitamin A deficiency. Now the trend is slowly getting changed. Okay, always look for it. Okay, and B complex deficiency also. Commonest problem, B complex deficiency, they will have. Okay, always look for it.
Yes.
Okay, proceed. B complex deficiency manifests in the oral cavity, no?
Yes, sir.
Oral cavity as?
Chelosis
form
and
of?
glossitis. Chelosis and glossitis.
Angular stomatitis, glossitis. Why? Why B complex deficiency manifests in the oral cavity?
The highly multiplicating cells in the oral cavity.
Yeah, the rapidity of cell division and the replacement of mucosal cells. Once in 72 hours, the mucosal cells are rapidly replaced. Any replacement, any division of the cell requires B complex factors as the coenzymes. NADPS, DPNase, all that. So any B complex deficiency usually manifests in the oral cavity. That too, as an angular stomatitis, it is very common because the angle of the mouth is the place where it is maximum mechanical stress has been happening. So that's the most commonest site. Okay, proceed, proceed.
Yes, sir. The chest showed rachitic rosary and Harrison sulcus. He had a pot belly with no striae and there was no umbilical hernia.
How did you examine for rickety rosary? How to examine for rickety rosary?
We should observe from the sideways.
From sideways.
In the supine position from the side of the...
No. Make the child stand, raise the hand above the head so that the bone becomes more subcutaneous. You can see from the front. Making the child to raise the hand above the head. Okay. So the bone will become more, that is the rib cage will become more subcutaneous. Then you can appreciate this by looking at it. For palpating the rickety rosary, always stand at the back and run the finger from the back to the front. When you are running the finger from back to the front, you can appreciate the rickety rosary. Okay. What is the DD for rickety rosary? Scurvy, you get scorbutic rosary. This is rickety rosary. One more condition is? One more rosary you get is in chondrodystrophy, other chondrodystrophy, mucopolysaccharidosis. Okay. In mucopolysaccharidosis also you get the costochondral junction is more prominent. There also you get this prominent rosary appearance. How to differentiate scorbutic rosary from rickety rosary?
Sir, rachitic rosary, there will be rounded angulation and will not be tender, and sternum also will be projected forward.
Sternum has got nothing to do with this costochondral junction. Sternum is separate. Okay. When the costochondral junction, when you are running the finger from back to forward, you appreciate this rickety rosary. This rickety rosary will be globular swelling. Okay. Globular swelling. And it is non-tender. Okay. Whereas in scorbutic rosary,
there will be angulation, there will be tenderness.
There will be an angulation. In scorbutic rosary only, you will get an angulation. Why you get an angulation?
Because of the subluxation of the joints due to the defective collagen.
It is the subluxation of the costochondral junction. So you get the angulation there. And it may be tender. Tender. Whereas rickety rosary will not be tender. The third one is mucopolysaccharidosis, where here it is globular. There it is something like spindle shaped. Okay. You have to stand in the back of the child. The child must raise the hand above the head. From the back, you have to run the finger and you must appreciate this. Okay. Scorbutic rosary, rickety rosary, how to examine is important. What is Harrison sulcus?
Where do you look for this?
Harrison sulcus, where do you look? Yeah.
There's a line in the lower margin of the ribs because of the constant pulling of the diaphragm. The softened
lower margin of the rib. Lower margin of the rib is you mean the costal margin. Costal margin.
Where the diaphragm attaches to it.
The crust of the diaphragm is inserted in the costal cartilages. The diaphragm is inserted like with the crust. When the costal cartilages are very soft, the crust pulls the costal cartilages. So you get an horizontal line. Okay. This is the Harrison sulcus. You see at the level of the episternum. This Harrison sulcus you see at the level of the episternum because of the crust of the diaphragm pulling the soft costal cartilages. Okay. Pot belly. Pot belly or protuberant abdomen. It is protuberant abdomen. You see pot belly. Okay. Why you get this pot belly? Why do you get pot belly in rickets?
Because of hypotonia, sir. Hypotonia.
Because of one of the reason hypotonia.
Any other reason?
Maybe there may be visceroptosis.
Okay.
Visceroptosis. What is visceroptosis?
Due to the laxity of the ligaments, the organs will be displaced downwards.
because the organs like liver and spleen are all holded by the ligaments. Because of the laxity, the hormones are dropped down, visceroptosis. So that gives the appearance of this pot belly. Protuberant abdomen, is it normal for children?
Normal till 4 years of age.
Between 1 to 4 years, protuberant abdomen is normal because of the waddling appearance, waddling gait. Okay? Okay. Proceed. She said about the sternum. Sometimes the sternum, because of the softened sternum, it may be incurving of the sternum, or sometimes protuberance of sternum may happen. That's why you get this pigeon chest or recurvatum. Sternal inward pulling of the sternum. Anything could happen in case of vitamin D deficiency. Okay. Proceed.
The wrist showed widening and he had normal fourth metacarpal. The lower limb showed genuvarum and flat foot and double malleoli. There was no bony tenderness, kyphosis or scoliosis of the spine. He had bilateral descended testes and there was no micropenis.
Okay. Widening of the wrist accepted. Why you were looking for normal fourth metacarpal, ma? Anything associated?
Pseudo-hypoparathyroidism, sir. Hypoparathyroidism.
Yeah. Pseudo. Yes. Okay. Genuvarum. How did you appreciate genuvarum? Make the child stand and you have seen genuvarum.
So there
Always.
is increase in the intercondylar distance.
Genuvalgum and genuvarum. Genuvarum you appreciate by making the child stand. Okay. This is bow leg. Valgum deformity, always you see the intermalleolar distance. Okay. Double malleoli, how did you examine?
Near the medial malleolus, there will be two projections. Just about the medial malleolus.
Run the finger over the medial malleoli from above downward. You will have two hump. Okay. Flat foot.
Because of the absence of the longitudinal arch of the foot, there will be flattening. Yes, sir. You can make an impression of the foot on the paper.
Yes, that's another way of doing it. You get this flat foot because of?
Can be physiological in infants.
Infants, it is physiological. As the age advances 1.5 to 2 years, the longitudinal arch starts developing. Okay. In rickets, the flat foot is the reason being? In rickets, everything, the reason is the same. Laxity of the ligaments. Okay. Because of the laxity of the ligament, the arch has not been formed. The foot will be flat. Flat foot is observed. Okay.
Okay, sir.
Okay. Double malleoli, only while the child starts walking or standing for a long time, you appreciate double malleoli. Otherwise, double malleoli may not be seen. Okay. This is only 14 months. So be very careful before mentioning all this. You must get better convinced about this double malleoli. Okay.
This widening of the wrist, how did you appreciate it? What is the best way to look for it?
You can ask the child to place, like you can see the dorsum of the hand.
Yeah, you have to raise the hand above and then look for it. Then it's better appreciated. Because sometimes if it's lying down and obese children and all, it may look like a false widening. So you lift the hand above and then look for it.
Likewise, one more thing about marasmic children. Marasmic children also, the wrist may appear little prominent, but it is not because of rickets. Because the bone is very subcutaneous and in marasmus, it is very thin. So you see this. Usually marasmus children are not prone to get rickets. Why? Marasmic children are not prone to get rickets. Why?
They'll have normal protein level.
No, nothing to do with protein.
Growing bone, sir.
Yeah.
So only
rickets
after
is
treatment.
a disease of the growing bone. Whereas in marasmus, when the child, marasmus is a well-adapted child. The child adapts to the available things. So it is not, the growth itself is retarded. So they don't see. Whereas in kwashiorkor, you see the vitamin D deficiency manifestation. Whereas in marasmus, many times the bone may appear more prominent and you may mistake it for rickets. It is not right usually. Okay. While treatment, as Sir says, while treatment, you come across the problem of rickets while treating. Yes, proceed, ma. Proceed.
Examination, cardiovascular examination revealed normal first and second heart sounds with no murmur. Apical impulse was felt in the fourth intercostal space. Respiratory system examination, normal vesicular breath sounds were heard on auscultation with no added sounds. Per abdomen, he had a soft abdomen, pot belly was noted, and no organomegaly. Cranial nerve system, he had no cranial nerve deficit. Sensory system was normal. There was no abnormal sweating noted. Motor system revealed a tone and power appropriate for age, and bulk was symmetrical on both sides.
So, what's your provisional diagnosis you like to offer? You just enumerate the positive findings in the clinical examination. You just tell us what is your provisional diagnosis.
You mentioned no abnormal sweating. What for you have looked for?
Autonomic nervous system.
Yes, sir. Hello,
Okay.
sir. Yes, sir. There was no abnormality in the autonomic nervous system, sir. Can I proceed, sir?
Enumerate the positive clinical finding and finally give your provisional diagnosis.
Okay, sir. He had frontoparietal bossing and he had frontoparietal bossing, rachitic rosary, Harrison sulcus, genovarum, double malleoli, and flat foot with widening of wrist. So these suggest more the skeletal features of rickets, sir. And the summary being a 1 year, 2-month-old toddler boy of first order, born to non-consanguineously married parents, with history of bowing of legs and delay in walking, with examination showing disproportionate short stature, moderate acute malnutrition, and skeletal features of vitamin D deficiency, as stated. In the absence of pallor, icterus, and signs of other vitamin deficiency, hypertension, alopecia, hepatosplenomegaly, cataract, and hearing loss, with no family history of similar ailments or chronic illnesses requiring medications and frequent follow-up, I would like to offer a diagnosis of rickets, probable nutritional etiology, with moderate acute malnutrition and with no other vitamin deficiencies.
Okay. Why do you say it is nutritional rickets, ma?
Sir, there is no alopecia, sir, so that is more commonly seen in vitamin D dependent rickets, sir. And there is no
Vitamin D dependent type 2 rickets is how often you have seen? No. You are talking only about alopecia. Yes, how often, how many cases you have seen so far in your 3-year career?
Only one case of ETR type 1, sir.
So why are you giving so significant to that?
Sir.
You tell me, what makes you to think it is nutritional rickets in this child?
Sir, disproportionate short stature is more common in nutritional rickets, sir. So
but disproportionate short stature will be seen in all rickets.
Yeah, okay, sir.
It will be seen in all rickets.
Okay, sir.
Then there is significant calorie deficiency is there, sir.
Calorie deficit, nutrition.
Yeah.
This failure to thrive may be seen even in your resistant rickets. There also the calorie intake is going to be less. To clinically differentiate whether it is a nutritional rickets or resistant rickets, the following points always you consider. 1, age group. Nutritional rickets is common in what age group?
In 6 months to 2 years age group, sir.
Yeah, 6 months to 2 years, nutritional rickets is very common. Whereas resistant rickets is supposed to be more common after 3 years, after 2 or 3 years. Okay, 1 age group. This child falls under 1 year and 2 months. 1. Number 2, okay, associated vitamin deficiencies. That is why I asked you specifically, is there is any vitamin A deficiency, B complex deficiency, anything is associated. So associated some vitamin deficiencies will be usually seen. with vitamin D deficiency rickets. Here, no such point to support you. Okay? If it is going to be resistant rickets, the child may have polyuria, polydipsia, or any other problem, say acidotic breathing. Okay, something like any other problem may be associated. Some family history may be present if it is going to be resistant rickets. Family history will be usually absent. Okay? Upper limb deformity and lower limb deformity, any idea about it? Upper limb deformity is more commonly seen with nutritional rickets, whereas lower limb deformity is more commonly seen with resistant rickets. Why so? Any reason? This is one of the reason, one of the differentiating feature given.
When does it start?
So you yourself are saying, Janapriya,
Sir?
sir is giving you some clue.
So only when the child starts mobilizing, so like the child starts crawling and the child starts walking.
Only after walking the disease process starts. So the
Resistant rickets usually common starts only after third year, fourth year, only after walking. So the lower limb deformity is more commonly seen in resistant rickets. This upper limb deformity, because the child while crawling, that is during 6 months to 1.5 years, 2 years, while crawling, if the child gets the deformity of the upper limb, it is nutritional rickets is supposed to be common. Okay, these are all the differentiating feature. Final, of course, we give this trial therapy. Okay, STARS regime, we used to say, now it is not the STARS regime, we give the oral vitamin D. Okay, these are the differentiating feature between the nutritional rickets and resistant rickets. Age of onset, then the associated vitamin A deficiencies, associated vitamin deficiencies, then the other symptoms like polyuria, polydipsia, acidotic breathing, all that. Then the upper limb deformity, lower limb deformity. These are all the reasons usually, the differentiating features.
Okay, sir.
Okay.
Yes, sir.
Okay. I think the possibility it is nutritional rickets, but anyhow, I want to rule out the any resistant rickets is the etiological factor for this child. Okay.
Okay, sir.
Anything, sir? Anything? How are you? How are you going to proceed?
Sir, I would like to do investigations for vitamin E deficiency and associated malnutrition to look for iron deficiency anemia, sir. So I'd like to do serum calcium, 25-hydroxy vitamin D, alkaline phosphatase, X-ray risk, complete blood count, and peripheral smear as the first baseline investigation, sir.
Okay. What is the, if at all, the first investigation if you want to do to confirm whether it is rickets, what is the first investigation you will do?
Sir, 25-hydroxy vitamin D, sir.
No.
which is the one which is elevated first? Pardon?
Alkaline phosphatase, sir.
Alkaline phosphatase you should do first.
Yes, sir.
Okay.
Okay.
Alkaline
What is the cutoff you take in an infant or in an older child?
Sir, 10 to 12, sir, serum calcium.
Growing infant, growing child, say up to 9 years or 10 years.
Sir, 20 to 140 international units per liter, sir.
No. What is given in Nelson also you have not told. But they say nowadays infants up to 500 we can take it as normal and older children 1000. We should not start evaluating if we find out this value also. Nelson they used to give 200 and all.
Okay.
Why alkaline phosphatase is elevated in children, ma?
So osteoblasts, sir, because of osteoblasts.
Sorry?
Osteoblastic activity. Osteoblasts are the cells which secretes alkaline phosphatase. Alkaline phosphatase. Due to osteoblastic activity, alkaline phosphatase may be elevated. Is it possible to have alkaline phosphatase level decreased in rickets?
Yes, sir, hypophosphatic rickets.
Okay. What about in nutritional rickets? Is it possible to have alkaline phosphatase normal values or lesser values?
When is it reduced?
When they're on treatment, sir.
Protein energy malnutrition with zinc deficiency is there. Zinc deficiency is there. Alkaline phosphatase level may be normal or lesser than normal. Okay, in PEM children, it can happen. Okay. Okay. What about this 25-hydroxy vitamin D level? What is the normal values?
Sir, about 20 is considered as sufficiency, sir. 12 to 20 is insufficiency, and less than 12 is deficiency, sir.
No, please tell the units also, Janapriya. What 20 means what?
IU, is it international unit?
What is it? What 20? What value?
Or nanograms per
milligram, nanogram, microgram.
Nanogram per. Just 20 nanograms per ml. So anything about 20 is sufficient. 12 to 20 is insufficient. Less than 12 is deficiency. What is the toxicity level?
Above 100.
Above 100, yeah. Now, what will happen to see you put it as investigations? Now, what will I would like to know whether the calcium level will be normal or decreased or increased. Just doing a serum calcium alkaline phosphatase, can you just I mean, when you tell the investigation, you like to know whether the value will be normal, increased or decreased.
Maybe normal.
What will happen to in this child with all the reports that you have been serum calcium? What will happen?
Sir, initial stages it will be normal or low normal, sir, calcium level.
Okay.
And
what is the normal level of serum calcium?
10 to 12, sir. mg per dl.
10 to 12.
10 to 12 mg per dl, sir.
What is the method you will collect blood for calcium? Any special precaution you will take while collecting the blood for calcium, especially if you are seeing a child with tetany? You are seeing a child with tetany. Before injecting calcium, you will collect the blood to assess the calcium value. What precaution you will take while collecting the blood? Anything special?
Sir,
yes?
We can collect in a heparinase syringe, sir,
that are all true. While collecting any special thing, because the thing is, if you squeeze the muscle, when you are doing the venipuncture, if you are squeezing the muscle, you will get a false calcium value. The intracellular calcium escapes from the cells into the circulation. So without squeezing the muscle, you must collect the blood. That is the method, especially when you are doing it for tetany, you have to do the protein level also, albumin level also you will do. Okay, both you will see. Okay, to see the ionized level of calcium, this is the ideal method. You should never squeeze the muscle for collecting blood for calcium. Yes? Calcium and phosphorus, what is the relationship? Serum calcium and phosphorus. Both are? Calcium and phosphorus level, both are? No idea. Both are inversely related. Whenever there is a rise in calcium level, there will be a fall in phosphorus level. They are inversely related. The product will be maintained almost normal. The product is supposed to be 40. If you say calcium is 10, the phosphorus will be 4. The product will be maintained roughly around 40. If the calcium is 8, phosphorus level may be 5. But in rickets, whether you have to see whether it is calciopenic rickets or phosphopenic rickets. This is again important. Okay. Phosphopenic rickets, the incidence is very, the common cause is hypophosphatemic, very mainly. Can happen with other conditions. It's very common. Okay. So X-ray is one of the important thing. Okay. Many times the rickets may be asymptomatic. You may be taking an X-ray for some respiratory problem. Your radiologist will report there is a costochondral widening. widening. They will report it's a case of rickets. Go and check. They may see the upper end of the humerus and they will tell us, go and take the vitamin D level and find out, go and check whether the child has rickets. So many times we have had this, and the radiologist making the diagnosis, and we retrospectively go and check the vitamin D level or look for rickets features. This do happen. Okay, this is very common in our setup. What about the prevalence of, you said the less than value 10 nanogram is deficient. Okay, you know the prevalence of the deficient values in your sanicity in children?
It will be around 40%.
In children? What is your
40%.
idea? What do you think about? You give some value. What do you think is the prevalence of vitamin D level? You are aware?
No, sir.
20%.
Not aware.
Definitely.
Around 45 to 50% of the population is showing less than 10 nanogram in this community. Okay. So do they all manifest with vitamin D deficiency features?
No,
Do they
sir.
all have vitamin D deficiency feature?
No, sir.
Okay. You keep aside. You go and read about all that as a postgraduate. Okay. There are a lot of things going on about this. Okay. The prevalence of vitamin D level among the general population, whether they have any clinical significance. Okay. 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 Proceed. You have done the investigation. X-ray will be very ideal. X-ray, both wrist has to be taken. Why both wrist you want to take? Both wrist or both knee? What is the DD? What is the DD for rickets?
Metaphysical issue.
Yes, come on, Rajshekhar.
Yes,
You are
tell
right.
loudly.
Metaphysical
dysplasia we show on, sir. It will be symmetrical, sir.
Which one will be symmetrical?
Metaphysical, sir.
No.
It will be lower
rickets, in rickets, almost all bones will be involved. Whereas in metaphyseal dysplasia, only one tibia may be involved. The other tibia may be normal. So there only it is asymmetrical. Okay. Metaphyseal dysplasia is the commonest DD, which may not have any significance. You do calcium level, phosphorus level, alkaline phosphatase level, everything will be normal. In metaphyseal dysplasias. So what is the commonest contour dystrophy? What do you mean by contour dystrophy? Yes? What are contour dystrophies? Anybody? In the long bone, okay, the long bone has got a metaphysis, diaphysis, and the epiphysis. Epiphysis is the chondral. Contour dystrophy, any abnormality of the cartilage, okay, that produces contour dystrophy. Commonest contour dystrophy we come across is the rickets. Rickets is the commonest contour dystrophy. Mucopolysaccharidosis is one another contour dystrophy. You have many bony abnormalities. Okay, bony abnormalities producing. The commonest contour dystrophy is rickets actually. Okay. Many of the other things may be congenital problems. Okay. Okay. This rickets, many times it may be, you may suspect vitamin D deficiency rickets. If you are suspecting vitamin D deficiency rickets, how are you going to proceed, ma'am? How are you going to proceed?
With treatment, yes, sir. I'll start him on oral vitamin D, 60,000 international units weekly for 6 weeks with calcium supplement of at least 600 milligram per day, sir.
You know about the previous plan, previous regime, what we used to treat, how we used to treat?
Fast regime is
it goes by the name, regime.
Fast regime, sir.
Fast regime. What is the regime? Fast
6
regime.
lakhs
So 6 lakh international unit intramuscular injections.
Divided
Beyond 1 year of age, you give 6 lakhs. Less than 1 year, you can give 3 lakhs actually. After giving, what you will do? How long you will wait?
For
Yes?
Around 6 weeks, sir. 6 weeks.
Actually, within 3 days, biochemical abnormality may get corrected. Within 3 weeks, you get the radiological changes to happen. This is what usually we come across. But STARS regime is now almost obsolete because of the fear of vitamin D toxicity.
Toxicity.
The complaints of the patient is the problem for us. Many times you tell them, you are asking the mother to take this vaccine, she has not taken. You have told the mother to take some calcium and vitamin D supplementation, and as well you have asked her to take some iron, she has not taken. These complaints of our patients are very poor. That's the only threatening affair for us. Even if you advise this oral vitamin D weekly for 4 weeks or 6 weeks, whether these people are taking it regularly, it becomes a problem for us. Okay, so that's the problem. STARS regime is almost obsolete. It is not even mentioned in the recent text. Okay, but at least you better know what is STARS regime. Okay.
Why do you want to give calcium along with vitamin D?
To prevent
Why do you want to give calcium along with?
To prevent something called hungry bone syndrome, sir, which usually happens when we are.
No.
Calcium is needed for vitamin D helps in calcium absorption, sir. So calcium is needed. So we will supplement this calcium, which is taken by this vitamin D, sir. So we can prevent hungry bone disease. I mean, hungry bones.
So usually a few weeks after initiation of 25-hydroxy vitamin D therapy, the calcium starts moving from blood to the bone, leading to hypercalcemia. This usually happens due to normalization of PTH. This is exactly called hungry bone syndrome. To avoid this, adequate calcium intake like 30 to 75 milligram per kg per day should be ensured and should be supplemented. And calcium supplementation should also be continued till vitamin D therapy is reduced to daily maintenance. Till then, we have to continue calcium supplementation.
Okay. What are the other options of treatment? Like instead of giving weekly once, is there any other option of treatment?
Daily treatment is 200 international units per day.
Sir. Sorry?
2000 international units per day we can use.
2000 to 4000. 2000 to 4000 IU you can give.
Per day for 3 months.
For how many days?
3 months, sir.
Okay. Again, along with calcium supplement.
Calcium.
What calcium supplement is the best actually? You know, you have got different salts of calcium, no? What calcium supplement is best actually? Which calcium supplement has got more of element calcium that is best absorbed?
Calcium carbonate.
Sorry?
Calcium carbonate. Calcium carbonate.
Right, okay, good. Calcium carbonate. How much calcium carbonate? Because it contains more of elemental calcium, it is best for absorption. It contains 40 milligram of elemental calcium compared to other calcium gluconate or calcium phosphate. Okay, so calcium carbonate is the best calcium salt to be supplemented with vitamin D actually. So once your course of treatment is done, what is that you substitute vitamin D? Then how long do you advise them to take it, or what is the dose of vitamin D supplement for this child? This is treatment actually. Do you complete the course of for 6 weeks and then just leave the child, or what do you do?
So we'll reduce it to daily maintenance.
What is the dose daily maintenance for this child?
600 international units.
DA.
Yeah, so it's above 1 year child, no, 14 months. So 600 international units per day. So probably just follow it up regularly, then okay.
Can you tell the good source for calcium, dietary source?
Ragi, sir.
Milk and milk products.
Milk, nuts. Okay.
Do you routinely repeat serum vitamin 25-hydroxy level after this course is complete? Do you routinely repeat? Suppose you repeat it, and what is the value expected actually? Sometimes or when you can repeat it vitamin D level after the completion of treatment?
One second.
So target vitamin D level more than 30 nanogram per ml.
No, there is not necessary to repeat as long as the child shows the clinical symptoms or other biochemical parameters like alkaline phosphatase, if it is increased coming back to normal, then no need to repeat. But sometimes serum, when we do a vitamin D, suppose post therapy, sometimes it may show a toxicity level also beyond 100. In that case, you would like to treat the toxicity level, or what do you do? What are the symptoms of hypertoxicity of vitamin D?
Symptoms of hypercalcemia can be seen for irritability, nausea, vomiting, constipation.
Irritability.
Yeah, so sometimes there'll be irritability, polyuria, polydipsia, constipation. So in that condition, then probably look for serum calcium level also. And then if it is hypercalcemia, or sometimes there may be hypokalemia, then or sometimes any urinary abnormalities or nephrocalcinosis, then you treat the toxicity. But if the value alone is more than 100 nanograms per ml without any symptoms, no need to treat the toxicity level.
Okay.
Right?
One another basic question. This child has got a deformity, bowling. Okay. You are giving now vitamin D. What will happen to this bowling? By giving vitamin D, what are you going to achieve? Mineralization of the bone? Is it right? You get my question?
Calcification of the bone. Yes, sir.
Yes, calcification of the bone. If the bone is already deformed now, okay, deformed in the sense it is the bowling. If you are going to give vitamin D, the limbs are going to get ossified or mineralized in the deformed position. Am I right?
Yes.
So what you are supposed to do is,
Splinting or osteotomy.
yeah, do the splinting or POP correction and then give vitamin D. In the corrected position, if you give vitamin D, the bone will get ossified in the corrected position. This will be the right method. If the deformity is very severe, where you cannot correct it properly, that case you need to give vitamin D, make the bone mineralized, and then our orthopedic surgeons will do osteotomies, bone correction, bone carpentry they will do. Okay, this is the correction they will do. Otherwise, do a POP casting or splinting, correct the deformity, along with then give the vitamin D. This is the right method. Okay. You get this point, ma'am?
Yes, sir. Yes, sir.
This is important.
Okay, sir.
Whenever deformity is there, try to correct the deformity and then give vitamin D. Okay.
See, there's a couple of questions from the audience, Janapriya. Or some people have one question they've asked is like the role of renal function test and urine analysis in this case. Should we do routinely in rickets or as a second line investigation?
It can be done as a second line investigation when there are no other systemic involvement is noted. So like the child only has this from the history and examination, it looks like a clear-cut nutritional rickets, sir. If the child is not responding to vitamin D therapy, we can then proceed with other investigations. So if the child has symptoms or signs of other system involvement, we can do the second line investigation, sir.
Why parathyroid level not shown in investigation in this child? Significance of doing parathyroid hormone levels. There's another question. Why serum parathyroid hormone was not done in this child?
So in this child, we specifically didn't do because of affordability reasons, sir, but otherwise we would have definitely done.
Hyperparathyroidism is expected. For all cases of rickets, you expect secondary hyperparathyroidism.
Yes, sir.
Okay? Okay.
The clear cut of nutritional deficiency, I don't think you need to do routinely parathyroid. Obviously, if serum calcium level is going to be low and hyperparathyroidism is going to be there. Maybe unless and until vitamin D dependent rickets or you wanted to rule out any other issue, then you can do a parathyroid issue. I don't think it is routinely required.
Routinely not at all required. Don't mention this in the exam.
There is one more question that intermalleolar and intercondylar distance. Should we mention it when presenting about bow legs?
No, knee.
No, it is. I think, sir, it is. It should not be measured. If it depends on whether it is genu valgum or varum deformity, then I don't think it is just basic how to differentiate it is a valgum or varum, and how do you identify it? Is that is the reason? Probably we should, sir, ask like whether it is intermalleolar or intercondylar distance.
For valgum deformity, you always measure the intermalleolar distance. Okay, that is knock knee. Normally, it must be less than 0.5 centimeter. Okay, for valgum deformity. For varum deformity, what you are supposed to do is hip, knee, and ankle. HKA. Okay, in the erect posture, you take the X-ray, a line, straight line, passing from the center of the hip, passing through the center of the knee, passing through the center of the ankle. Okay, normal angle. If there is a deviation of this angle, then you assess the degree of the varum deformity. These are the methods of estimating. This valgum deformity, usually this is knock knee, is significant mainly for services. What services? Military services. For military services, usually they take the candidate to look for the knock knee. So the intermalleolar distance they measure actually. And if they have the intermalleolar distance more than 0.5 centimeter, they are unfit to join the military service. So this is the reason why it has been being done usually routinely. In military service, while running, they have the hindrance if they have some knock knee, so they are unfit to join the military services. Okay, varum deformity is usually measured through the hip, knee, and ankle line, HKA.
In the investigations, why you have not mentioned about serum phosphorus?
Calcium and phosphorus.
Any reason for not mentioning?
Typing error. But Janapriya.
So when the child improves,
No, probably she has looked at the cost factor and she didn't want to do it.
Calcium and phosphorus routinely to be done. Calcium, phosphorus, alkaline phosphatase is routinely has to be done with the X-ray.
Okay.
This is the X-ray of the patient, man.
Yes, sir.
X-ray of the patient, showing cupping, fraying in the upper limb. What about the lower limb? Not taken.
No, sir.
And the costochondral junction widening is seen, very nicely seen, the anterior end of the rib, with some amount of fraying. What about the upper end of the humerus? Upper end of the humerus, not well visualized. There is no irregularity seen at the metaphyseal end. Okay, chest X-ray also shows the evidence for rickets, and the both wrist also shows this cupping and fraying. You know the reason for cupping and fraying? Why you get cupping in the X-ray?
There is loss of convexity at the metaphyseal end of the bone.
Why you get this? It is the pressure effect. Pressure effect. As the child crawls, because of the pressure effect, you get this cupping. Okay? You get fraying. Why you get fraying appearance?
It's because the edge of the metaphyseal loses its sharp border, sir.
No, fraying means something like sun rays, something like sun rays, no? So this fraying appearance is because of the defective mineralization. These minerals are getting deposited along the capillaries. Okay? The mineralization is defective, you get. If you understand the rickets, the long bone formation, what pathophysiology is happening in rickets, you will understand about this fraying and cupping appearance.
Yes.
What will happen when you are giving vitamin D and repeating the X-ray? After giving, yes?
Provisional zone of calcification will be.
What do you mean by provisional zone of calcification? Why you get this provisional zone of calcification? Usually the minerals are getting deposited at the tip of the capillaries. Okay? The capillaries will be normally growing at the metaphyseal side, whereas the minerals are getting deposited along the vessels in rickets. Once when you correct it with vitamin D, at the tip of the capillaries, which were normally growing, you get the calcification done. And then it proceeds downward. So the provisional zone of calcification is the place where, if the bone is growing normally, where mineralization should have occurred, is the site where now the mineralization is happening when you are correcting it with vitamin D. If time permits, I'll show you how the normal bone grows, and I'll tell you how it happens exactly.
Yes, sir. Can I?
See, there's one last question. What is the role of 125 dihydroxy vitamin D level measurement, and which condition we measure it? There's a question from one of the participant here, Janapriya. Do you have any answer for that?
Yes, 125 can be measured in BDDR, sir, or in.
Okay, routinely, we don't measure 125
No, sir.
dihydroxy. Only if you're suspecting vitamin D dependent rickets, then we measure 125 dihydroxy level.
To know
To
the
differentiate
difference,
between whether it is type 1 or type 2.
Type.
So there's no routine measurement. No need to do it actually.
Okay.
and one more question, the same person has asked lower limb deformity more than upper with normal tone. So hypophosphatemic rickets is more likely, sir.
Phosphorus level is not examined. Hypophosphatemic rickets has to be ruled out.
Okay. Okay, sir. Okay. Hello.
Yeah, proceed, Janapriya.
Yeah, okay, sir. Sir, Adam, I'd also suggest a diet plan, sir, with the increased consumption of fortified milk, egg yolk, fish, and to meet the recommended daily allowance to meet the RDA and also to meet the calorie recommended for the child, sir. And supportive therapy such as oral iron supplementation and to increase playing in outdoors, so to increase playing in the sunlight and to avail Anganwadi services to meet the nutrition and immunization needs for the child, sir.
Okay.
Yes, sir. So this can be a sample diet plan, sir. I just modified it based on the previous one, sir. By adding 2 teaspoons coconut oil in jaggery, the calorie levels can be increased, sir. And by also consuming 200 ml of milk, he'll also be meeting the calcium levels, calorie levels, and also be consuming more amount of vitamin D2, sir.
Calories. Okay.
Yes, sir.
Okay. So 980, roughly around 1000 calories
Yes,
you
that
are
is,
providing.
yes, sir. Right. Or
Okay.
if they are more willing for including other diet, this diet can be followed, which will provide 1046 calories, sir, which will include ragi with sugar, milk with sugar, and more consumption of oil and.
Okay. So roughly around 60% maybe from carbohydrate source, 20% from fat, 20 to 25%, 15% to 20% is from protein. Okay.
Yes, sir.
All this composition must be almost maintained, to be maintained. You have added oil. Okay. Oil is considered as one of the packed calories. Packed calories. Okay. Why they are considered as packed calories? Oil is considered as packed calories. 1 teaspoon of oil gives you around 45 kilocalories. No? So it is considered as packed calories. So whenever there is deficiency of calorie deficit will be there whenever you are calculating the food. So you add this oil. What oil you prefer adding? What oil you prefer?
Coconut oil can be added, sir.
Why? Why coconut oil special? Not from Kerala. You are from Kerala?
No, sir.
No. Why coconut oil special? Cooking coconut oil.
Yes, sir.
Yes? They contain medium chain triglyceride, MCT. Okay? MCT is absorbed without the help of bile. Okay? It is directly absorbed. It doesn't need any lipase enzyme. Okay? Medium chain triglyceride. That's why you supplement, even in the preterm babies, you give coconut oil being sold by different trade names. Okay? Coconut oil is sold by different trade names. Not aware. MCT oil.
Yes, sir.
Okay? This is medium chain triglyceride. But problem with coconut oil for adult, I want to take coconut oil. Is it allowed?
No,
Elderly people, it is not preferable oil because
LDL.
of saturated fatty acids. They contain saturated fatty acids. Okay? So it is not a preferred one. For smaller children and for growing children, this MCT is the ideal. This coconut oil is the ideal one. Okay.
Okay, sir.
How will you plan immunization for this child since the child has not received?
What is missed opportunity, ma? Who has missed the opportunity now? Missed opportunity.
Hello?
You are aware? Missed opportunity.
Sir.
So they're eligible for vaccination, but either partially or not receive vaccination.
Whenever the child comes to your outpatient department, when there is no contraindication for vaccination, if the child was not vaccinated, you subject the child for, you advise the mother or the caretaker to give the vaccine for the child. You don't miss the opportunity. This is the missed opportunity. This child has not taken any of the vaccine. Okay. What are all the vaccines you can give now? As Sir has asked you. What are all the vaccines we can give?
Sir, DPT, IPV.
IPV, DPT, IPV availability itself is the problem. Yes. DTP, IPV, not OPV, yeah?
HIB, sir. OPV can be given, sir.
Yes, OPV. HIB.
HIB.
Yes.
Hepatitis B, sir. Hepatitis B.
Hepatitis B, yes. Yes.
Measles, sir. MMR vaccine.
Yes. MMR can also be given along with that. Yes. These are the vaccines may be given together. There may not be any worry. Only thing is rotavirus is not supposed to be given. Child is beyond 8 months. So you cannot give. Rotavirus, don't give. Okay. Other vaccines we can give. Okay. So don't miss the opportunity. The child has come for some other problem, that is for rickets. But then don't miss the opportunity. You give the vaccination for this child. Okay. You can include in the management schedule, you can include this missed opportunity. Don't miss the opportunity. I am planning to give immunization. You have included, no? Avail Anganwadi services to meet the nutrition immunization needs. Okay.
Yes, sir.
Yes.